Hey, I'm Jim Wiedrick. Every day I'm working to transform healthcare in Southeast BC. One of my big ideas is engaging smart folks in one-on-one conversations, looking for opportunities to improve patient care, explain how we're doing things in our healthcare system, and analyze for the average everyday folk what the path ahead might look like. I'm really stoked today to be joined by one of my respiratory therapist colleagues at Kootenay Lake Hospital, Mitch Wilkey. Hey, good afternoon, Mitch. How are things in your neck of the woods?
Hi, Jim. How you doing?
I'm having a good day. I can see a little sunshine out over my shoulder, and it just helps this time of year to have a little extra vitamin D. So that's a big bonus.
I would agree with that. Yeah.
So let's pretend you're my mother, and you've never heard of a respiratory therapist. What's a respiratory therapist do in the great big system that we've created in our neighborhoods?
Yeah. I mean, there's a few ways to look at that. And I used to, when I first started, I used to describe that as if you ever did a first aid course and you had to know your ABCs of airway, breathing, and circulation. Those are the main roles that I'm involved with in patient care. So realizing that algorithm is kind of swapped around a little bit these days, but yeah, anything to do with from premature babies all the way up to adults, anything that is going to involve breathing. So whether that's because they can't breathe on their own and we have to help them through ventilators and those types of things, or it can be things like chatting with someone and diagnosing or going through the diagnosis of asthma or emphysema or something like that, and giving them the education that they need to better manage their disease process. So I could be sitting down in front of them at a desk, or I could be at the head of a bed in a trauma room. Either way, quite intimate sort of connections with patients.
Yeah. No, thank you. So regular viewers of this podcast will know that my primary work gig is in the emergency room. So maybe let's dive a little deeper on what a scenario might look like if I'm on shift and a very ill patient comes in and we say, hey, call the respiratory therapist for help. And you've always been very gracious. You're pretty flexible, even if you're at home and you can answer your phone. You'll come in and help us if we ask on a critical care case. So I'm imagining a case where within the first minute or two of a patient arriving, I've determined that they need to be intubated. Could be for a lot of different medical conditions, and maybe they need to be transported out to a tertiary care hospital. But I'm looking for your help. So if we call Mitch and Mitch hits the emergency room door, what's going through your mind? What kind of steps are you doing, thinking about? How do you see your role at that point? Here we are with a critically ill person.
Yeah, I mean, because I'm usually elsewhere in the hospital, I usually kind of arrive at the scene right at a point of critical intervention. And if I'm lucky, I will get like a very short sort of, this is the situation, this is where we're heading, like you mentioned, intubation. So I don't have a lot of time to kind of like, oh, what direction are we going? What therapies? I am going to switch gears pretty quick, and I'm already entering that trauma bay, looking at the team, um, and looking at where everyone sits with their roles if that hasn't already been defined, and then I'm eyes on the patient. So I've got a little bit of a short, 30-second sort of brief. This is what's going on, and I'm looking at the patient, and most of the time, I do have tasks I have to do, but the way I approach it, and I'm sure other RTs do the exact same thing, it's all about anticipation of what could go wrong and how can I be one step ahead of that, and what are my plans A, B, and C if this particular step doesn't go well. So for me, I'm looking at the patient, looking at, just by assessment, by looking at them, looking at vitals, looking at what medications are hanging there and that sort of thing, getting a quick idea of what's happening and what direction we're going. And then it's about preparation of how I can best assist the physician in that intubation. So then it's checking equipment, making sure all our bits and pieces are going to be there and available, and not just the ones for that specific task, but what's plan B and plan C, and making sure all of those are, at arm's reach. And then also looking at the patient in terms of how can we optimize them fully before we even begin this whole process, and whether that's positioning the patient or pre-oxygenating them or those types of things, getting them into a good position. Again, it's all about anticipation, and the more I can be 2 or 3 steps ahead, that's gonna, if we do run into a snag, I'm already there, trying to help with that. So coming into that room, like, this is all these kind of things are running through my brain in a very short period of time, because usually when the decision is made to intubate, most of the time, if we're lucky, we have more time to talk about our plan, and get organized. But most of the time it's a short, minutes, to kind of get organized. So then it's, I'm going to be at the head of the bed. Hopefully we've all communicated all those types of roles, and seeing what we can do. The good thing about these days compared to when I started my RT position back, now I'm pushing 22 years now of being an RT, we didn't have visualization on screens. We didn't have any GlideScopes or anything like that at that time. So whatever was happening as far as visualizing the cords for whoever was intubating, I had no idea really of what they were seeing. Whereas now I look at the screen as well, and then I can kind of see, is there some manipulation that I can give to assist with that intubation. As the tube's passing through the cords, I can help with removing stylets at certain timing to make sure that the tip of the tube can draw up into the cords and those types of things. So it's a huge benefit, not just to the intubator, but to me as assisting someone who's intubating, having that GlideScope visual, to the visualization for me as well.
Yeah, I mean, you're referencing these video laryngoscopes, and they were game changers in my practice when I first started using them back in, I think it was about 2006, 2007. And just like you say, it took the task from just one person who had to have these direct eyes and could only have a narrow field of vision, and everyone else had to assume or hear from them what was going on. And now you've got a TV screen, in effect, that can basically show the room what that person is seeing, and it definitely facilitates the procedure and lowers some of the risks. I mean, it's not without its own challenges, but it's a big help for teaching and or for assisting. And in that scenario, you're the ultimate assistant, aren't you?
Yeah, absolutely. Yeah, and I totally agree with that point too when it comes to teaching as well, is that, everyone gets a little look at that, and often there'll be a resident or a medical student at the bedside as well, and it's a great opportunity for them as well. So yeah, that, like you said, game changer. And I've been doing this long enough where there's been certain devices that I think are just made huge improvements in how we can give care to our patients, that GlideScope being one, and I think OptiFlow also as well. That was a game changer as well. But yeah,
well,
so
just before, I would love to talk to you a little bit about OptiFlow and the like. I have a distant memory, and I know my teenage listeners won't know what I'm talking about, but George Clooney on an episode of ER, grabbed the video laryngoscope of the day, and this is in the mid-90s. And, within like 32 seconds of TV time, he'd gone from assessing the patient to having them successfully intubated, and I was just this is why I can't watch this program. This is not real life. It does take a little longer, even if you're super slick.
Yeah.
If anybody's interested, look up YouTube ER George Clooney intubating somebody.
Yeah. I too had difficulty watching that show after working in Emerge. I started my career at Vancouver General Hospital, working in that Emerge, and that is not how those environments run like that. And so, friends would say, is that what it's like? Or that must be really cool. You must like that show. But I just found it frustrating because it was, not at all. And if someone run an Emerge room like that, it would be a high anxiety process, I really do appreciate how we approach it in real life.
real life is just a little more real somehow. Yes. Hey, okay, so let's segue into maybe the patient doesn't need to have a breathing tube, doesn't need to be intubated or those kind of things, because you've hinted at a lot of things there. Some of these other technologies that have come to the fore in the last 10 years, Optiflow is a particular brand name, but just tell us a little bit more about how that rolls or what benefit it has for folks who are in our emergency department.
Yeah. So, obviously, putting a tube into someone and having a machine breathe for them comes with its consequences as well, right? And so if we can have options to avoid doing that, and, either it's to align with their wishes or it's could be complicating down the road. It's nice to have other modalities at our fingertips, and one of them I think is Optiflow, and it's a way of giving oxygen that is heated and humidified, and so our bodies love having nice 37 degrees on the inside, and not that cold or even room temperature air coming in. It's like stepping outside to shovel the driveway when it's minus 16, and that first breath in is quite assaulting to your lungs and makes you cough. And if you have dry gas, like oxygen being pounded into you that you need, your lung tissue is not a big fan of that. So Optiflow allows, or that heated humidification allows us to provide humidity, which our lungs like to be nice and moist, and keep our body temperature or the gas that we're delivering at body temperature, so we're not spending that energy and oxygen and chasing our tails to try to warm it up. The other bonus is that we can deliver it at higher speeds or flows. When you're sick and you're working really hard and sucking in a lot of air to try to get that breath in, and you've got oxygen on it, that can dilute the amount of oxygen we're trying to give that patient. So the heated humidified oxygen allows us to try to match how fast they're sucking in. So they're primarily, and therefore also creating a reservoir in the back of your mouth, allows you to deliver higher concentrations of oxygen that will be able to meet that demand. And that was a major limiting factor for a long time. We could deliver high amounts of oxygen, but not fast enough, or we could deliver it humidified, but not warmed up to body temperatures. We could deliver it humidified, but it was aerosol as opposed to a vapor, which has consequences in terms of infection control issues. So I really think that device really allowed us to have patients either on a medical floor or in Emerge and prevent having to either intubate them or put them on another modality like BiPAP. It's not the be all, but it can help us in that regard for sure.
Yeah, and I'm sitting here listening to you and thinking, it must have been really hard to be a respiratory therapist right in the depths and the hustle and bustle of the pandemic. That must have been like next level. I know my own reaction to it, but I can think we can safely say we're mostly through it. But as you look back, what kind of reactions, what kind of experiential, deep, guttural kind of thoughts were you having?
Yeah, I mean, when I first started my career, SARS was happening, and and I was literally, it either was my graduating year or my very first year as a respiratory therapist. Can't quite recall. And I was working in the ICU in Vancouver, and so most of the cases were happening out east in Toronto. But I remember that moment of donning all of that respiratory, all the protective equipment, masks and gloves and gowns, and entering the room in ICU to provide respiratory care. They'd be on a ventilator. It was, eye-opening. It was like, whoa, this is the career path I chose, like putting myself in that position. Like I can't get any closer to an infection that no one has. We didn't have a clue really what was happening at first. And so that was like a mini introduction. And realizing, I had exposures to rabies and other sorts of things as you do it, as you start to log on years in medicine. So when COVID hit, same sort of thing was rolling through my brain in terms of, I see it coming as it's making its way over to Canada, and then it's going to end up in Vancouver, and that's going to end up in the interior. The difference is with SARS, when I first started my career, I was in a unit where there was, or my respiratory department was about 80 staff of respiratory therapists. And, there's senior staff there, a lot of education being spread around. So now, COVID, I'm in a respiratory department of 2. So that support network that existed before, in terms of a respiratory therapist, was not there. As far as let's bounce ideas, let's share ideas, what are you hearing? I am very appreciative of the KLH where I work and the team that's there. I'm very thankful for that team. I feel like my skills are appreciated, and I do feel appreciated there. And so even in times like that, where we're sitting with you and nursing educators and other staff, thinking no information had disseminated to us yet, and we were trying to figure out what are we going to do. And I was reaching out to colleagues. A good friend of mine is an anesthetist in Comox, and I was like, what are you guys doing there? So anxiety for sure. Not I wasn't frightened, but definitely anxiety was present, and I didn't realize that until in the moment. It wasn't into probably 3 or 4 months into it when I'm still going to work every day. The entire town is shut down, and my family's home, and I'm going to work and showering before I come home, and all those types of things. I'm not even vaccinated yet. It was it wasn't until just after that time that I realized that it was affecting me mentally. But again, looking back, knowing that I'm going to be in the room, a negative pressure room, with a couple colleagues, the physician who's going to be intubating and a nurse who's going to be giving drugs, and it's just the 3 of us. And at first, we'd be in there. I've shared that room with you plenty of times, for hours, all gowned up and, trying to provide lines and all that sort of thing. And the lack of information was frustrating, and then some of the information seemed conflicting, and but still very thankful for the team at KLH. Communication was really good among us. Our ideas were all well respected, so that made it easier for me to go through that for sure.
It's almost strange to think, hey, that was 5 years ago, almost anyway. But there were so many clinical scenarios in the year 2020 that were just groundbreaking. We were kind of charting a new path, and none of us had really lived through that. And at least so much of medical education, goes in the neighborhood of see one and then do one. Well, okay, I've experienced this, or so-and-so showed me how to make sure this goes right. And you were like, I'm just starting from scratch. I was on a call with somebody from New York City, and they told me they like it this way. Oh, okay. Let's give that a best try.
Listening and watching many emerge physician podcasts from New York, as a way to get information. It was pretty wild at that time, because
imagine if it had been 30 years earlier and we were all trying to rely on newspapers and magazines that came out once a week. I mean, we would have been way behind the 8 ball if that was the case, because the internet age and the way to share things visually and in around the world style certainly has its benefits in those regards.
Absolutely.
And we have to also cherish or honor the difficult journey that it was for so many people, whether it was the patients, whether it was their circle of influence, whether it was us as caregivers in our circle of influence. It was challenging. It worked your adrenal glands and all the different parts of your brains, and sometimes it people need to just stop and say, wow, that would have been tough, and that is something that perhaps we aren't really great at sometimes, but I want to say, hey, I can see that would be tough.
For sure.
No two ways around it, are there?
Intimate to those patients that are that sick, and really not knowing how that was going to play out for them. Because the reality is, our hospital, right, we don't have an ICU, and so we don't see what the next steps are, or at least and I don't get that kind of feedback of that experience we just had with that patient. Now they're somewhere else. Like you said, we do rely on experiences that we've had, and we build upon those. And when it's brand new, you're trying to look for that, like, hey, how did we do, kind of thing, like, are we on the right path with this? Because it was so new then. That was an interesting time for sure.
And then, so I want to segue a little bit into talking about the kind of work you do if someone has an outpatient consultation with you. But I'll ask, just as an opener, do you see people, or have you been managing and helping care for people who are effectively long COVID or have some lingering respiratory troubles from having had COVID? Or is the bulk of your work, when people come for outpatients, chronic obstructive pulmonary disease, asthma, and some of these other respiratory conditions?
Yes, as exactly the bulk of the patients I see in the outpatient clinic are going to be that COPD and asthma piece. Certainly after the Delta variant at the start of COVID, that I did see many folks struggling post-COVID. Young people still on oxygen, and so that's part of what I do as an outpatient, is help manage their oxygen needs and requirements as well. I don't facilitate, or I shouldn't say I don't provide the oxygen, but I kind of manage the direction that they go with their oxygen. And so, yeah, that was really shocking to have young folks that were on oxygen for months and months and months after COVID. But I'm not getting that very much anymore post-COVID. RSV last year, the year before there, was kind of rolling through for the adult population. We always see it in the young, but it seemed to be quite apparent in the adult population. And same sort of thing, a lot of folks needing oxygen for quite a long time after that. So sometimes I get patients sent to me for diagnostic exploring of, is there some long-term COVID effects, but there's nothing definitive in the kind of testing that I'm doing with the spirometry. Is that it's really hard to say it's because of COVID that you are like you are. But whereas management of chronic diseases like asthma and COPD, that's a big piece of what I do. And those patients, especially the COPD patients or pulmonary fibrosis patients or pulmonary hypertension patients that live in our community, once they kind of get into my realm, I build quite a relationship with them because I see them for years. And then, then I'll see them on the medical floor because if they're having an exacerbation, or maybe see them emerge. And what's special about that is they see a familiar face that they've spent 5 years building a relationship with as an outpatient, and they're in this time of feeling quite vulnerable, and very sick, and then they see me and they think, oh, Mitch is on my side. When all of us are on their side, but they see me as, well, at least he's here, and I definitely get that from the patients, which is quite rewarding to be able to provide that for sure.
No, I think that's super cool. We always need to be reminded and honor those who are providing that longitudinal care presence, because you're like an anchor. You're a kind of foundational stability. And even if there are other smart people or dedicated people coming and going, it's just like having that person you trust. I've already dealt with Mitch. I trust him. He actually is going to try hard to make me better. And man, I didn't know that when I was 20 years old. That was such a truth, but I can sure see it now on this other end of my career.
Yeah, absolutely. Yeah.
So there's one other little scenario that I thought was worth highlighting that you're sometimes involved in, and that's going to like the first hours of a newborn baby. And every now and then, we do about 250, 300 deliveries a year at our hospital. Many of them are perfectly well adjusted and immediately catch on to living in the new world just fine, but a few of them don't. So how often would you say you have to help out in the first minutes and hours at a birth?
Yeah. I would like to preface that before I came to Nelson and started working at KLH, I only worked in the adult world, and of course, I'd done some training with pediatrics, but I wanted to get as far away from that as possible when I first graduated and worked in the adult world. So when I came here, I had to pull up my bootstraps there and kind of get up to speed pretty quick because, all of a sudden now I'm providing that ventilatory support for a newborn. So that was anxiety driving when I first moved here. And now it's still a stressful time, but I have a lot of experiences under my belt now. And again, it's another team that I really appreciate and really love working with is the maternity and pediatric staff. They're awesome. So some babies come out earlier than they should. And, things aren't fully developed. And one of those things is lungs. And or maybe they come out a little bit early and the shifting of all the fluid and all the things that happen didn't happen for whatever reason. And so now their lungs are really wet and heavy. And those are really hard for a little baby to start moving around, trying to move some air through that. And so I need to provide some support to kind of help lower their work of breathing. Often those babies are going to need just a little more time. So those are more frequent, where it's not as traumatic, where it's like a baby born at 26 or 30 weeks, which does happen. And due to our geographical location, we can't just ship them down the road quite easily. So we do have to hang on to them until infant transport can come and get them. And so we are kind of forced into that to stabilize them. So yeah, we do get babies like that.
Because often their destination is going to be Children's Hospital in Vancouver, correct?
Yeah, exactly.
A big plane flight away, and not that easy in the depth of the winter, a dark night, a snowstorm.
Yeah. And what people don't know is that you can't just even fly into Nelson. You're going to be flying into a neighboring town, and it's still an ambulance ride to get to that neighboring town before you can get on that plane to fly to Vancouver, and depending what the roads are like. So yeah, sometimes you end up hanging on to a baby for 18 or 24, 48 hours. So yeah, it's quite, again, another kind of a special thing to be a part of, whether it's a resuscitation of a baby that comes out in the OR room, or whether it's or at delivery, and then providing the ventilator support until transport can arrive. One of the I actually just saw as an outpatient recently. I have this young lad who I see now for asthma reasons, but he was born in a hospital, and I provided a lot of ventilatory support for that guy, and it's so wonderful. I get so excited when he comes in for his asthma reviews and follow-ups, and he plays hockey, and he brings me his little hockey card with his little picture on it. It's so great that I was a part of that very first moments of his life, and this is a cheeky little lad, just like any guy his age, giving his mom the gears a little bit, but I've been seeing him for years now, and yeah, that's quite special.
That's
to be
super cool.
Yeah, yeah.
And you do a little bit of traveling to some other sites for clinics from time to time. Is that still true?
Yeah. So when I said we have a department of two, so there's myself and another RT, and so primarily I am based out of Nelson now, but for about 10 years, that was a big part of my role, where I would go to Nakusp, New Denver, in Caslow, and provide outpatient care at those sites. And so that's looking at asthma, COPD, and home oxygen stuff. But I also, those sites, there's no RTs in that world up there. And so they get a new ventilator or a new piece of respiratory equipment. That was also, I do in-servicing and making sure the staff are up to date with that sort of stuff. So that was really, I really like that. And then when you're talking to those patients that may end up at KLH, and you're just more familiar with where they're coming from when you get to go out to those communities. And so then that makes that connection when you see them down the road a lot more, I don't know, like they have a lot more trust in you, when you can understand where they're coming from.
Everything's more meaningful.
Yeah, absolutely. Yeah.
So if I gave you a magic lamp and as many wishes as you wanted, like what, as we rub the lamp, would you want to conjure up? Do you have big things where you're like, yeah, if we could just have that, that would be something that was more optimal?
I wish there was more of me,
Okay, more Mitches. Yes, just
Yeah,
put you in the cloning machine and
yeah. I
replicate
wish
you
there
or
was
something
more
like
of
that.
me. Be- you know, I do. I, I feel really accountable to this town and this area, and it drives me to try to do as good a job as possible that I can within the means that are provided to me as far as my how many hours I can work and how well we're staffed. Um, but there are limitations with that, and part of that is like in the middle of the night, maybe, I'm not available to come in, and I find out the next day that I couldn't, and I know I shouldn't carry that, but I do. And because I wish I could support my team, and I can't always do that. So I do wish there was you know, more of me in that sense, where we can provide more reliable in terms of always being available to come in and provide that support. If I had any wish, that would be certainly that.
Yeah. No, and I hear you, and that is the thing. If you're trying to provide a service and cover the entirety of the day and the calendar and the year and all that kind of stuff, you have to be able to divide it a few different ways. It's not a one person thing. You can't work all day and work and be available all the time through the night. No, right on.
Yeah.
Well, I mean, I celebrate the gift of service that you have given us, and so thank you for doing what you do. Yeah.
Yeah. Thank you, Jeff.
Hey, Mitch, I'm really grateful that you took the time to be part of this podcast. If people have questions about respiratory therapists or like, I would be happy for them to drop a note in the comment below, and I'll make sure to monitor that and get back to them or circle it over towards you. I am always pleased to just speak to people who have a real heart of compassion, and I can see that you do. Thanks, and
Thanks, Jeff.
we'll catch you on our next shift together.
Sounds good.
Bye, Mitch.